Good evening. Welcome to the 2017-2018 Schroeder Lecture. I am Sharona Hoffman, the co-director of the Law Medicine Center. The lecture is named for Oliver Schroeder, Jr., who joined the faculty in 1948. In 1953, he founded the Law Medicine Center, which was the first law school program in health law in the country. The lectureship was established in Ollie's honor when he retired in 1986. And the Schroeder Scholar is selected on the basis of scholarly distinction and contribution in the arenas of health policy and law. So today we are very honored to have with us Dr. Ali Khan, who is wearing a bolo tie, I am told, in honor of Ollie Schroeder. He is a Rear Admiral and the Dean of the College of Public Health at the University of Nebraska in Omaha. He's also a retired Assistant Surgeon General. There are a few seats up front here if people are looking for them. Before joining academia, Dr. Khan had a long career at the Centers for Disease Control and Prevention in Atlanta, where he served from 1991 to 2014. That is where I met him when I did a sabbatical at the CDC in 2007. Dr. Khan began his career at the CDC as an epidemic intelligence service officer, and he had many positions after that. The CDC has very long and complicated titles, so I am not going to read them off to you. But one of his most important positions was as director of the Office of Public Health Preparedness and Response. Dr. Khan received his Doctor of Medicine from the State University of New York and completed a joint residency in internal medicine and pediatrics at the University of Michigan. He also holds a Master's of Public Health from Emory University. Dr. Khan has focused his career on bioterrorism, global health, and emerging infectious diseases. He has been instrumental in numerous important initiatives. Just a couple of examples are that Dr. Khan helped design and implement the President's Malaria Initiative, a $1.2 billion five-year project to reduce the burden of malaria and relieve poverty in Africa. He has also been engaged in polio and guinea worm eradication. Dr. Khan has numerous publications and many other accomplishments, and we are very honored to have him with us and look forward to his lecture.
Good afternoon, everybody. So, thank you very much, Dr. Hoffman, for that very generous introduction, and thank you very much for the invitation to join you this afternoon. I must say I'm very humbled to be here as a non-lawyer, and I will be very honest with you, my initial inclination was to say no when I was asked to give this lecture, but I'm not sure how many of you know Professor Hoffman. That's not an option with Professor Hoffman. So I said, glad to do it, and then I did some homework on Dr. Schroeder. It turns out that the pressure was even more than I thought to come and give this lecture to an audience, such an esteemed audience. Turns out that Dr. Schroeder was a war hero, established, as you heard, the oldest medicine law program. The only thing that made it a little better was, as I read a little bit more about him, it turns out that later in his career, he turned out to be quite a fun gentleman. I'm not sure if that's the right characterization, would have various comments he would make about holy kittle humper. Somebody's going to have to explain that to me. And he apparently started wearing bolo ties. So this is the first and ever bolo tie. I actually bought this bolo tie last week. And I'm not sure I'll ever wear it again, but I will wear it today to try to channel Dr. Schroeder. But more importantly, I want to try to channel his energy for the next hour, because there was a comment about him by Mr. Donald Rumsfeld, who said that he kept him up and alive and awake at 7 a.m. in the morning for his lectures. So apparently this is a quite esteemed gentleman, so thank you for increasing the pressure on me even more, Dr. Hoffman. Okay, so today is the eve of Hallows Eve, and at least somebody got that memo about what today was. So I'm going to tell you a ghost story. That's my plan over the next hour. And we're going to talk about witch doctors, zombies, and oracles, and see how that references rethinking health in America. And I'm going to be very careful. You notice I didn't say health care in America. I said health in America, and I'm very deliberate about the choice of that word. Let's see, come on, you can do it. Oh. Let's start with who is somebody who's often attributed as the first physician, Hippocrates, but I'd like you to think a little differently about him from now on. I'd like you to think about him as the first public health doctor in the world. When he says things like, it's more important to know what sort of person has a disease than to know what sort of disease a person has. Okay, so we're going to do, as I said, we're going to do a ghost story, and like all good ghost stories, there's a beginning, there's a middle, and there's an end to all good ghost stories. And let's start with the beginning of our ghost story. Apologies for that. I may just not be pointing in the right direction. So our ghost story is going to start off with the health of America. Where are we? And we're going to start with then we're going to how are we getting there? And eventually, where are we going? So let's start with some of the myths in healthcare or zombies that just refuse to die, okay? And those include American healthcare system is the best. Well, you can read these faster than I can say them, right? Read them quickly, right? Employment, uninsured, free markets, universal coverage is too expensive and unaffordable. Hopefully by the time we're done, you will agree with me that these are all zombies. So let's start with the health of America and where we are now. And I will introduce you to the greatest boogeyman that exists in America. The society papers are claiming that because of the movie It, how many people saw the movie It? Some of you did. Not the evil clown movie, Stephen King. Not my genre, but apparently this is, not my genre. I saw the Blair Witch Project 20 years ago. I still can't sleep. But this is apparently the year of horror. I would say it's horror a lot more than what's out in the movies, but unfortunately. But healthcare is one of them, and here's my shock slide to start you off with. So these are projected increases in healthcare premiums over the next year. Okay, so I like to start with this because no matter who's in the audience, you all have health insurance or some version of health insurance, and this resonates with everybody in the audience. This is what you're experiencing in your pocketbook today. So what do we pay for health care? A lot. $3.2 trillion in health care. Almost 1/5 of the U.S. economy is spent on health care in the United States. And that, I'm sorry, this lag is sort of getting to me here. Let me see if I can shut it off and turn it back on if that helps. Okay.
Are you trying to go back?
No, I wasn't. No, it's...
We're bringing help.
No worries. New batteries, maybe? Okay, we're back in business. Okay, and what you'll notice here is the increase in costs for healthcare compared to the increase in GDP in the United States. Okay, and you all know this in your wallets as you think about what your copays look like, and your employers sure know this as they think about what their health insurance costs look like. And these dollars we spend more than any other country in the world on healthcare, at least 2 to 3 times more than on any other country. Now, let's talk about where this money goes. The first place it goes is health insurance companies. So look at what the increases are. You don't need to worry about the numbers. I just want you to notice the curves at each of the largest health insurers in the United States, what's happening to their profits. They're not suffering. Now, a big part of what drives healthcare costs are inpatient costs, not inpatient costs, but that was pretty good. It was close enough, but it's inpatient costs, about 40%. And I guess if you've been hospitalized, you probably are inpatient. But drugs also drive a large chunk of these costs, and that shouldn't surprise you. This looks at how many people are taking prescriptions, and I can say statistically, over 1/3 of you in this room are taking a prescription currently. 1/3 to about half of you are taking prescriptions right now, and about 1/4 of people are taking 2 or more prescriptions. And you'll see by year what the proportion likelihood is of you taking a prescription drug. So by the time you're 65 years of age or older, you will be taking at least 1, if not 2 to 3 prescription drugs. And again, I showed you profitability for health insurance companies. This is the same exact profitability as you look at drug companies, and nicely going up. And in this increase, there's a whole lot of abuses within drug companies. So here's some of them. I think the Martin Shkreli probably resonates with everybody in this audience, where he took a critical drug that you need for people with HIV/AIDS to help them prevent an infection, and you jack up the price from $1 to $375 the moment you buy the company. It's a generic drug available anywhere and readily made. And Mylan did the exact same thing with the EpiPen when they markedly jacked up drug prices for a generic drug, easily made, readily available, but they own the ability to make it. Now, there are some consequences for this to try to drive these profits, and you in this room know the consequences very well, being from Ohio. And it has to do with, in this case, look at opioid drug abuses and what's been going on nationally with opioid drug use. And what I don't show you on this slide, but I plucked from your newspaper this morning, is your Attorney General, is it Devine, is actually suing 5 pharmaceutical companies to recoup the costs of this opioid epidemic. Many parts of Ohio are actually ground zero for the opioid epidemic. And by the time this day is done, 14 people in your state will have died from a drug overdose. And there's lots of evidence that these drug companies were promoting OxyContin and other drugs when they were not indicated, and were involved in the efforts to help convince physicians and nurses and healthcare providers that pain was your 5th vital sign. And so you had to ask everybody about pain, and unless they said they were pain-free, you needed to start to give them narcotics. And many people now, there was a new indictment, this is the right audience, of a company that made this sort of oral formulation. So it's like a spray formulation of a very, very addictive narcotic that's only meant for a very, very narrow group of people. And basically they were trying to promote it to anybody and everybody to start giving out this spray for this very addictive narcotic because it made tons of money for them. Lots of examples. So that's a little snapshot of what you're paying for healthcare. And Throughout this, what I'll do is try to throw in a slide that can serve as discussion at the end of the talk of what I see as some of the critical health law issues as we think about prices, authorizing Medicare to negotiate prices, fast-track generic drug approvals, anti-price gouging. These are all critical issues, I believe, critical health law issues. So that's how much healthcare costs. Now there's a flip side to that, right? So I've said we're spending about 1/5 of the U.S. economy on healthcare. The flip side is, what are you getting from that, right? $3.2 trillion. What are we Americans getting from this $3.2 trillion investment in healthcare? Well, the first thing we're getting is we sure aren't insuring everybody, right? This is the data, different age groups, in this case, different ethnicities in this group, showing that despite that sum of dollars, we still do not have universal coverage here in America. How are we spending those dollars, right? So you think, oh, well, we're spending them in all age groups to make sure people are staying very healthy throughout their lifestyle. That's not true either. That's not how we spend healthcare dollars in the United States. We spend, let's see, the top 1% of spenders account for more than 1/5 of all spending. So 20% of all healthcare spending in the United States, 1% of people account for that. So these dollars aren't even distributed equally across age groups to make sure that they're driving health and not health care. We also don't get the quality you would expect out of these dollars. So this is looking at our life expectancies in year based on the cost, so the amount of money we're spending in healthcare. And it's a nice curve. It kind of makes sense. The more you spend up to a certain point, you will end up having greater life expectancy. But then you have the outlier, right? That's us. So despite how much we spend on healthcare, we have absolutely the worst life expectancy, worst infant mortality, worst maternal mortality, worst number of people with 2 or more chronic conditions of any developed country, period. We tend to be at the bottom all the time. The example I often use is around infant mortality. So our Healthy People 2020 goal is 6 children, 6 or less children dying of 100,000 who are born every year. 6. Can somebody guess what the number is if I go to Scandinavia? 2. Brilliant. Absolutely. So our standard is 3 times less than what other countries have already achieved in life expectancy. That's our standard, that we're trying to get 3 times worse than what other countries have already been able to achieve. And actually that's your data. 5.8 in the United States, 3.4 if you look at other developed countries. And Japan and the Netherlands dropped that down to 2.1, if not less. I showed this. This is the same sense, but this now looks at ethnicity, and I'll talk a little bit about how this health system not only doesn't give us access to care, doesn't give us good quality, it sure doesn't give us equity either. The way it's currently structured. This looks at age-adjusted death rates by cause, race, and sex. And what you'll notice is essentially for each and every one of these conditions, we happen to have a discrepancy based on ethnicity. And those discrepancies in ethnicities also can be seen as we look at life expectancy. So you see clear discrepancies in life expectancy by ethnicity, and sometimes not what you expect. So if you had to choose what race and ethnicity you wanted to be to live the longest, it would be Hispanic females, absolutely. At least first-generation Hispanic females. You give them enough generations of our diet, and it changes a little bit. But that would be the choice you would make. So we need to rethink equity in the United States, and how do we make sure people are getting health equity. And ethnicity and race are easy because often you can just look at somebody and make that determination, but that's not true for all other causes of inequity within our health system. For example, urban-rural inequities that we have within our health system, and also gender inequities that we have within our health system. I'm a big fan of Dr. Perez Stable, who's the director of the National Institute of Minority Health and Disparities. And he talks about some of the disparities within gender and minority populations, and talking about that on average, they live 12 years less than other people. So you can't look at somebody and say, hi, you're a different sexual orientation, and we need to take care of you. So really you have to think about how are you baking equity within your system so you're addressing everybody's needs. This gives you some of that sense of the urban-rural divide. Again, something you wouldn't see just looking at somebody, but look at the difference in life expectancy for, I think this was an 8 or 12-hour drive I checked, between Oglala, Lakota County, 67 years, and Summit County, 85 years. So this is in the United States. You probably go a little farther than the distance of the longest width of Ohio, and you have a discrepancy of almost 20 years in life expectancy. Okay? Completely, I would say, unacceptable here in the United States. And these discrepancies is why people often talk about zip code as a better predictor of life expectancy than genetic code. So in Omaha, I can tell you that if you grow up if you're born about a 15-mile difference, you will have almost a 15-year difference in life expectancy just from where you're born. Not the hospital you were born in, but where you live. That will tell you 15-year difference I can predict for somebody. And I think what this goes to is why I use the word health instead of the health care. And it's because as we look at other countries and our relationship to other countries, it's important not just to look at what are we spending in health care, it's just as important to look at what are we spending in social and health services. And how do you put those together, because it's that combination that really will help you determine what health in your communities looks like. How am I doing? Talking too fast? Am I okay? Okay. I'm from Brooklyn, and the more excited I get, the faster I talk about things. So this is absolutely one of my favorite slides of all time. It makes no sense to you. It's not meant to make sense to you. And actually, the fact that it doesn't make sense to you is why it's my favorite slide. So this was a great analysis that said, can we compare the size of hospitals with their outcomes? Can we compare your outcomes as patients with your experience? Can we compare that with the cost of your health care? Right? So is there some, clean association? You're paying a lot more, you're getting better quality. Or the hospital's bigger, you're getting better quality. And the reason I love this data is because you do not need to have a degree in biostatistics to say, no, none of it matters, right? It's just all over the place, and that's the point, right? And why I love this slide is that things intuitively you may think would make a difference. Like, I have the most expensive healthcare plan in America. I'm going to get the best possible care. It's not true, okay? And so another component about healthcare that I can't miss is how much is wasted in our system. From healthcare fraud, numerous articles every day about healthcare fraud. I guess there were 2,000 at the end of, I guess that one has 2000 and 2013 has the latest data. But every couple of days you see another group trying to bilk Medicaid or some other individual of healthcare fraud. This I want to show you because, let me see, to really make the point here, percentage of total healthcare spending that's spent on fraud. So the calculations is about 1/3 of your healthcare system. That's not just fraud. That's a little bit more broader in terms of wasted, studies that you don't need, tests that you don't need. But potentially 1/3 of the healthcare you receive is unnecessary. So 1/3, let's see, so 1/3 is healthcare you don't need. About 1/3 is administrative expenses to healthcare. So this is your insurance company's administrative expenses. So really the question I ask to you is, if I handed you $2 billion today, do all the crazy stuff you still do in medicine. So let everybody walk in the door and get an MRI. But take care of the fraud, take care of the administrative fees, and what could you in this room do if I handed you $2 trillion and said, here you go, fix health in America? Because that's essentially how much dollar there's at play within the system. And every time I hear somebody tell me there's not enough money for health care or for health in America, I go, that's absolutely ridiculous. There's more than enough money within the system to fix our health system. I'm looking forward to see what this slide says, like you. Oh, there you go. Okay. Oh, I know. Oh, hold on. That was a video I was supposed to show you. Hold on, hold on. Come back, come back, come back, come back, come back, come back, come back. Do we have audio back there on this? Say when. Can we have my audio here in the room? Okay, well, that was a learning experience. That's okay. It basically says what I said. And the example that's specifically given in that report is how we have repackaged anti-cancer drugs. So a number of anti-cancer drugs used to come into multi-dose vials, and you would just give the same amount for somebody who's petite and somebody who's not so petite, right? So you just, based on their weight, you give them the right amount of drug. But what a number of companies did is they standardized those doses, so they now come in single-use vials. And so you end up throwing, if it's too much for the person, you just end up wasting it down the drain. So there's millions of dollars of anti-cancer drug that you paid for that just go down the drain because of a decision made by a drug company to put it in a single dose vial. No reason to put it in a single dose vial except to increase the cost of the drug or increase the profits for the company. Okay, so that's where we are. Now let's talk. That was kind of depressing, right? Well, that was like a good, right? That was like a horror story, right? Okay, but all horror stories need some redemption, right? So let's talk about the fun stuff now. Okay, so let's talk about where we are going to go and how we're going to get there within the healthcare system. So this is the fun stuff now. Okay, so I want to talk a little bit about some of these things that are up here, and where is the sort of the health ecosystem going, as this probably is on track to potentially be over $5 trillion enterprise here within the United States. So healthcare is essentially eating everybody's lunch, and why there's not enough money for a lot of other discretionary activities we would like to engage in as a nation is because we're spending that money on healthcare. So a lot of this money goes into healthcare delivery, and increasingly that's changing. So for example, even now, people can, as we have access to data, so think about how you pay for healthcare. It's changing now, but it would be like going to a restaurant, having a menu with no prices on it, and what the restaurant charges you is different for everybody. Right? That's exactly how you pay for healthcare currently in the United States. That's changing. And as people are understanding what their co-pays look like and what it costs to do tests, I have patients who say, I can get my MRI cheaper if I go down the street to Johnny's MRI than if I happen to go to U's MRI, which is where you're sending me. So we're seeing that change in consumerism, and I'm actually quite hopeful that we will get to this sort of Uberization of healthcare. The only thing that prevents it is access to data. And for very clear reasons, you have very little visibility on what true costs are for any test you take or any condition you have until way after the fact. The other big move in public health is financing, and this is probably the one that makes me the most excited about where healthcare is going, and I'll give you the best example from my brother-in-law. So right now, healthcare is fee-for-service, right? So the more tests you do, the more money you make. Pretty straightforward system. It's the exact same system we had about 10,000 years ago, I would say. So 10,000 years ago, you would come to a witch doctor, right? Your head hurts. The witch doctor will give you a salve, you'd give him a chicken, right? That's 10,000 years later, it's the same thing. The salves have gotten a little bit more complicated. Now we have MasterCard instead of chickens. But it's the exact same way we've been practicing medicine for the last 10,000 odd years. Well, what's going to happen now is actually we're going to start paying for health and not health care. And the equivalent is that when my brother-in-law has to make the once-a-year journey to his mother-in-law, he lives in Houston, has to go up to New England. Many of you know this story, the yearly journey to the pilgrimage to the mother-in-law. And you take two young kids, you put them in the back of the car, and how long does it take for somebody to say, I got to go to the bathroom, right? You just went to the bathroom, or they're throwing popcorn around the car, or they're smacking somebody above the head, right? You've been there, you've been kids, many of you probably did this yourself. He tried to bribe them. He'd give them money and say, don't do this. Never works, we know that. So he tried a different strategy. He handed each of them a Dixie cup full of quarters. And the moment somebody said, are we there yet, wouldn't say a word. He'd reach back and grab some quarters. The moment somebody smacked somebody out on the side of the head, didn't say a word, grab some more quarters. Even a 5-year-old and a 7-year-old, it doesn't take very long for them to learn what the consequence of their actions are. And that is where your health care is going. So I, as your doctor, will get a Dixie cup full of quarters to see you and take care of you. And if I decide I'm going to do 20 tests on you when you need one, the insurance company is going to reach into my bucket of quarters and it's going to take some quarters out of there. And so for the first time ever, healthcare will be defined by making sure you, as my patient, stay healthy with obvious quality measures, because I guess the best way to game the system is to do nothing for you. But with appropriate quality measures, where we're going is this essentially a new way of financing healthcare that's about getting health for people and not this fee for care model. We're fortunate there's a large push for wellness within our communities, and that will continue to change over time. And greater push for public health and trying to make sure we have preventive services. How do we keep people from getting sick as opposed to taking care of them when they become sick? And there's a couple of issues here as I think of health law issues. One is around telemedicine. I'm not sure if you've discussed this. This is a real issue for us in Nebraska, is how do you get insurers to reimburse when you never actually physically touch a patient? And how is telemedicine different from a phone consult, and how do you reimburse that? And how do you address that in rural populations where you want them to stay within their communities and get care within their communities and maybe only see you intermittently when they really need some high quality service that isn't available locally? And then this whole issue of sort of where we're going is sort of black bloc algorithms and how much trust your patients will have if you tell them you have a type C3b cancer and the right algorithm for you is these 6 drugs. And the only reason I know that is because Google says it's these 6 drugs. Right? Because that's essentially where we're going in the future. And cancer has actually taken the most advantage of that. There's no way you as clinicians, and I'm very sure as legal practitioners, you can and do keep up with your literature every day. It would be the equivalent of reading probably 20 articles a day, right, of research articles. And you are going to have to need new tools that help you synthesize that and make sense of all that data and information that's coming at you. So this is where the new practice environment is going to be in the next 20 odd years. So the first is we're shifting to a majority minority population, right? So here are the projections by 2050 that the combination of Hispanics, Blacks, Asians, and others will outnumber the number of whites here in America. So we'll be practicing medicine in a very different environment, at least from a racial ethnicity perspective. And I would say the same thing is true as we think about rural-urban divides, as we think about gender equity issues also. Also, what we'll be practicing is medicine on a different population of people. And what you'll see here, this is a population pyramid, males and females. This is 0 to 4 going up to 100 plus. And see this little bulge in here? this is all going this direction, right? So these individuals are all getting older, and as they boomer population is, and so this is the population that increasingly is going to need access to and health care and all the costs associated with making sure that you're providing them care. So how do we get people? Another issue we'll be dealing with in the United States is a markedly obese population. 1/3 of us are currently obese, 2/3 of us are currently overweight, and obesity is on track. And this is so disturbing to me as a public health professional. Obesity is on track to beat smoking as the leading cause of cancer in the United States. Okay? Associated with over 13 odd cancers already. So this is going to be the leading cause of cancer in the United States, let alone all the other complications associated with obesity. And then we also have to think about in the next 10 to 20 years, what are the impacts of our behavior on our environment, and what is that going to mean for us as we think about climate change and things such as extreme weather events in the United States, right? So also, we'll have to think about the threat of emerging infectious diseases. I couldn't miss the opportunity to throw in this one. Antibiotic resistance, measles, Zika, whatever the next threat is. So we need a healthcare system that is going to be ready for all this sort of changing landscape that we're going to see ahead of us in terms of these broad demographic changes in our people and these challenges that we are going to have around obesity and chronic diseases and climate change, emerging infections. The next pandemic is coming. So this is what we need a healthcare system ready for, not just 10, I keep saying 10 to 20 years. I would say we need it ready today for this reality of what healthcare looks like. And we need a healthcare system that helps assure equity for our populations. And there's a couple of different ways of looking at equity, but how do we make sure the right set of resources are flowing to the people who need them to make sure that they are healthy? Okay, so where we were, where we'd like to be in this world, where there's more equity and a healthcare system that's responsive and ready for the changes that are ahead of us, but how are we going to get there? I told you he was the father of public health. I don't know why the physicians claim Hippocrates as the father of medicine. I think the public health people should just claim him as the father of public health. Okay, so how do we create healthier communities? There has been no better time than today to think about how to do this impossible. How do we take public health and healthcare and put them back together again? So I'm sure some of you in this room are super fan heroes, and all superheroes have an origin story, right? You know, Spider-Man got bit by a spider, et cetera, et cetera. Public health people also have an origin story, right? And their origin story goes back to 1850s, where a physician, John Snow, ring a bell? John Snow, Broad Street pump, cholera, take the handle off the pump, stop the cholera outbreak. And this was actually even before we knew what germ theory was. Well, a really wonderful and bad thing happened in 1850. And what happened was epidemiology became a science, and public health and healthcare started to diverge. And that divergence has continued over the last 150 years. And what the consequence has been starkly here in the United States is that we spend a whole lot of money on healthcare, but we don't spend anything on public health. And it is now time to bring those two together. And this is the most opportune time ever, because the health care system recognizes that they need to do better. And there are conversations now about healthcare 3.0. And the crux of healthcare 3.0 is about the triple aim, providing high quality care to at a lower cost to all of your population within your practice. But they are understanding, clinicians and healthcare systems, that they need to think about population-based health outcomes. They need to think about care integration that takes the individual from the hospital, recognizes that this individual lives in a community, and how are you addressing those needs within a community to help them become better. So the conversation now is about healthcare 3.0. And because of healthcare 3.0, people have started to talk about precision medicine. So precision medicine is how to use great technology to understand that Ali has a lung cancer. His lung cancer has these specific genomic messages, and I need to treat him with this specific profile of drugs for all the diseases that Ali could have. But I think it is also moving, and we know it's moving in the direction of precision, what I would say is precision medicine, when clinicians and practices are sort of learning that, maybe we should be stepping back a little bit. And it's not just about how do you treat my lung cancer, but how do you keep me from getting my colon cancer. And so this was the nice example I found from Geisinger, which is a health system, where they have a food pharmacy. And so they write you a prescription for food, right? For you and your family. You go once a week, you meet with a dietitian, you go there off the shelf, and you pick out 5 days of fresh, valuable food to help you get healthy, right? So a different way of thinking about what we write on that prescription pad that will have a larger impact on your patient than that statin you just wrote somebody, right? And I could extend that to think about exercise on a prescription pad if you can really get people to exercise. And Medicare is also recognizing this. So increasingly, despite what's been a slowdown in the last year, but I will say that this train has left the station about thinking about how do we pay for value and health, as opposed to how do we pay for health care, and how do we make sure that all of our new payment models really incorporate public health measures. So as a clinician, I can tell you already, I don't get judged on how do I take care of Mr. Johnson's blood sugar. I have to do that right. I need to make sure that Mr. Johnson's diabetes is taken care of. But what the insurance companies and payers are now saying is, you saw 600 people with diabetes. Tell me what their average blood sugar was. And if you're meeting that average level as a quality measure, it's a completely different practice environment for those of you who are physicians out there or about to be physician of what you're going into, right? You still need to, of course, provide exceptional care to that one-on-one interaction you would have with a patient, but your providers are going to ask you, what are you doing for your population as a whole? So you have 332 people with hypertension in your practice. How many of them have a controlled blood pressure? A very different question than, did I put Mr. Johnson on, pick a drug, atenolol, whatever, right? It's a very different question and interaction between you as a practitioner and your practice and in payers. And that's good news, though. And again, this did move backwards this year. There's a lot of new, what were called bundle payments that were supposed to be released this year by CMS that have been slowed down. But again, that train has left the station, and that is where we will be in 10 years from now, because our healthcare system is just so unaffordable. We need to have other options to try to address these costs. And part of this is what CMS is already doing as part of CMMI. This is their new innovation center, is to think about this individual you're taking care of with his blood pressure. He or she is not just hypertension, right? It's so easy as a clinician to say 65-year-old with hypertension, right? We all do it. Those of you who are clinicians, you'll recognize this, right? So this individual lives in a community, and there are these social determinants of health that determine how healthy they are. And CMS has even gotten on board to this concept that this is their pilot looking at what are called accountable health communities. I'll talk a little bit more about accountable health communities in a minute, but I didn't want to miss this point when I'm talking about how our payment systems are changing in the US, to say that these are a list of questions that within this pilot you will be asking your patients, right? The housing instability, food insecurity, transportation needs, utility needs, interpersonal safety. And so this is a different framing of that relationship, that patient-doctor relationship, healthcare provider relationship. So again, it's not just about the hypertension, but it's, are you addressing these other needs? Not you personally, right? Nobody expects me as a clinician to become a housing expert. But if I made sure that Mr. Johnson is connected to the right agency, that he's housed, right? And there's lots of examples across the United States of large systems where they bear the costs of these individuals who may be coming into the hospital again and again, that they find the best possible thing to do is house them. Another good example why housing is on this list is asthma. So 10 to 15% of you in this audience have asthma. And sometimes you have these patients who come in to your emergency room again and again with asthma, little kids who come in again and again. And there you are, you're putting them on your first line drugs, you're putting them on your second line drugs, you're putting them on your third line drugs. Well, do you know it turns out that you will have more benefit for this patient instead of tiering these set of drugs if you send somebody to the home of this child and look at the house and see what their environmental exposures are. And if you address those environmental exposures, you will keep that little kid out of the emergency room and you will keep them off a number of these toxic drugs. Just a different way of thinking. My favorite example besides asthma is people who have this severe lung disease, usually associated from lots of years of smoking. And you have people, and this study was lovely done in the Boston area, that you have people during the summer who keep coming into the emergency room every other day because because they aren't breathing very well. Well, if you send somebody to their home during the summer and you realize they don't have an air conditioner, that $450, $300 air conditioner has just saved you tens of thousands of dollars of that person not coming into your emergency room. Or when you tell a patient who has heart problems, check your weight, because if your weight goes up, it suggests you've got a lot of fluids, and they don't have a scale in their home, right? What have you just done? So it's a completely different way to think about practice. And it's this way to think about practice. And so this is the great alignment as healthcare has been talking about healthcare 3.0. Public health has long last said we need to be talking about public health 3.0. It's coincidental that they're both 3.0, but what is not coincidental is this realignment of public health and healthcare to say, how do we come together and assure that we're addressing these social determinants of health and assure that we're having healthy patients, healthy people, not just patients. We'd like to try to keep them from becoming patients, obviously. And the data here is very clear. This is a nice example that comes out of the National Association of City and County Health Departments, where they're able to show that if you have comprehensive systems in place for a community, you can decrease all-cause mortality within that community. Okay, compared to communities that don't have these comprehensive systems to take care of patients. This was really a great read to me, and to show that public health, working in that social determinants milieu, you can have a large impact on mortality within communities. And so this says that what we need to be doing is rethinking health care or health in a way that we're investing within our communities, right? And thinking of health as a part of the picture. Health, to determine your health, health is probably about 15% of what makes, health care is about 15 to 20% of what makes you healthy. All the rest of it is your outside environment, your outside set of activities that determine whether or not you're healthy or not. And here's an example I'm going to give you from where I am in Omaha these days for the last 3 years. So I live in Douglas County, which is where Omaha is. So basically, if you look at 78%, so this is essentially 4/5 of deaths in Omaha. If you look at those 4/5 of deaths, so I'm going to make you go backwards on this slide, so make believe you read Arabic. Go from 78 deaths to four chronic diseases, right? These 4 chronic diseases are due to these 4, count them, 4 unhealthy behaviors, right? Lack of physical activity, poor diet, substance abuse, and tobacco use, which I put in that same category. And these 4 behaviors are linked to 9 socioeconomic factors. So if I want to influence these 78% of deaths, early deaths within my community, you look up there and you go, where should you be working? Right? Should I be working on making sure I'm dispensing enough antihypertensives? Yeah, it's probably a good idea. But am I going to get a lot more bang for my buck if I'm working on issues around transportation, employment, housing, safe neighborhoods for people? Right? So just a different way to think about how are we going to get more bang for our buck to make people healthier. And housing, here's an example. You can read this faster than I can, but housing is a really great example, right? So as clinicians, we tell people you need to exercise, get out and walk in your neighborhood. Is it safe to walk in your neighborhood? Did somebody end up putting sidewalks in your neighborhood so you can walk and you don't get run over by somebody else? Does we tell people eat healthy? Okay, are there options within your neighborhood where there's more than Twinkies uh, to eat? Right. So it's easy to say these things, but we need to think about, are those things available for our patient and our communities? And so housing is a good example of that. I already gave you the asthma example, obviously. And so this calls for a different way of thinking about health in our communities that is more patient-centric, person-centric, community member-centric than it currently is. You'll see this surrounded by some of those social determinants of health and all the people and entities that need to come together to make that happen. And hospitals are just one important, but just one part of what we need to do as we think about creating these accountable health communities. And what I'd like to see is the following, and this is going to require data. I was having this conversation yesterday. So, do you know how Uber became $1 billion company? It's so simple, any one of you could have done it. What you did is you took data that says I have a car and I'm available with I need a car, right? That's Uber, right? You took these two pieces of information, you put Airbnb, whatever it picked, you put these two pieces of information together and you became $1 billion company. You don't own the cars, you don't own the people, you don't own the drivers, you don't own anything of it. The only thing you did is you put two pieces of critical information together. I'm waiting for that day in healthcare when we put these critical pieces of information together. So for example, let's pick a city, Cleveland. Can anybody give a good estimate of how much does it cost to take care, total cost, all claims, all payers, to take care of people within Cleveland? You can't. The data is not structured to allow you to do that. But think about the power if you could. So if I knew in Cleveland it cost me $100 to take care of everybody within everybody, and then I can go to Blue Cross Blue Shield, I can go to CMS and say, you know what, I've got a great plan in this community to help people with their blood pressure, with their diabetes, with their obesity, and I'm going to save you money. And then you realize that the next year or 2 years later, that $100 is $80. So I've just saved you $20, and then you pay me, let's say 10. Be generous, okay? So you keep 10 for you, you give 10 to me, and I will continue to work in this community to drop those $80 down to $60 of healthcare spend within the community, right? It's a completely different way of thinking about how any of you who are interested in working in the community improve health, where actually it's an incentive model, right? So if people ask, Ali, what keeps you up at night? What keeps me up at night is, how do I incentivize public health, right? How do I incentivize health? I've got a good model for health care. I know how to make money in health. Actually, I hope my $3.2 million has convinced you. Lots of people know how to make money in health care, right? We have not yet got the right incentive model to think about, how do I make money if my job is to make you healthy? Because that's not how the system is structured. But I think with good data, that is how the system could be structured. Now, it's not just about money, right? Because obviously, the best way to save money is if you get hit by a truck tomorrow, right? I'll save lots of money because I don't have to pay for your health care. It's really very good for me if you get hit by a truck. So it's got to be more than about extending long-term lives. It's got to be about that social responsibility component, that we'd like people to live healthy, because we know there are models of healthy aging out there, and models that we've not just embraced here in the United States. And then I can let you look at all of these. So these are some of the other critical healthcare law issues as we think about moving from Obamacare to what will be Trump care in the future, and what those consequences will be as we think about the legal implications. Some that disturb me immensely are losing essential health benefits for people, and soon you'll be able to buy these cheap association plans that pretty much promise you everything, deliver nothing, and appropriately cost nothing, right? So that's really worrisome. So these are sort of, issues that we're going to have to think about, is what is the right way to deal with them within our community. And then let me leave you, let's flip on this. So let's remove some of these zombies, right? So does America have the best healthcare system in the world? No, we don't. Not that I'd want to be in Central Africa if I got sick, but for the community as a whole, America doesn't have the best healthcare system. Employment does not guarantee health insurance in America, right? There's lots of people who remain uninsured. And the rest of these, we've gone through all of these. The biggest one is this one, right? I want you to challenge this one every day, right? So I don't want to talk about single payer or non-single payer. I want to start by talking about single coverage, right, or all person coverages, because there's lots of good models on how we could get all coverage and better care without going to a single payer system. We could have a multi-payer system, but are we making sure that everybody has got good quality health care? And it's not just access. We have lots of good data that access is not enough to improve health. It's definitely not enough to improve equity, but universal coverage is too expensive, too affordable, too complicated. Maybe it's still too complicated, but it's not too expensive, it's not unaffordable. As I said, I'm willing to give you $2 trillion today, each and every one of you in this audience, and tell me how you would improve the healthcare system if you'd be willing to let go of the fraud, waste, and abuse within the system, and if you'd be willing to let go of the 38, 35, whatever % of administrative costs within the system, so that every dollar really went into your community and went into your patient. So this is your challenge, right? What does that look like? Butcher shop, Photoshop butcher shop. Okay, that's your challenge, right? How in a community, when everybody wants to sell you health care, how do we change that to a community where we find a way to sell you health and not health care? And let me leave you with a quote by the great Dr. Ali Schroeder. The practice of medicine is moving from an amoral to a moral science aimed at preserving a healthy condition rather than intervening in a pathologic crisis. Who would have thought it? He was a public health practitioner also. Thank you, everybody.
Okay, we have maybe 5 minutes for questions. And so please try to keep them as short as possible, and the microphone will be handed to you.
Thank you very much. I was just wondering, when did healthcare in America become a business instead of a profession? And how are we going to fight against the food industry, the hospital industry, the physician industry, or the drug industry to bring about what you suggest?
So wasn't healthcare, so number one, healthcare was always a business. I'm not sure when healthcare wasn't a business. What has changed is the focus on the patient as opposed to the focus on the profit motive. And it changed as there was more dollars within the system and as health insurance became prominent and you didn't feel the full consequences of your decision. So some of you, many of you have pets in this room. Very few of you who have pets have pet insurance, and you pay the consequences for whatever happens to your pet. Healthcare would be very different in America and would cost very differently if I didn't have insurance and I had to personally pay my health care, which is why we're moving towards sort of more co-pays and where it matters to me if I get the MRI, but in the system I currently have, it doesn't matter to me if I get the MRI every time I bang something. So I think that's what happened, the insurance and the more money, the development of Medicaid and Medicare, which provided additional resources into the system that didn't exist before. So I think that's what the transition happened. As far as how do we get align the pharmacists and the pharmaceutical industry, and that's where I'm looking for solutions from you, is, what are those set of incentives? And they have to be monetary incentives. I don't know what I believe in this world, but I do know that greed works, essentially, right? And how does it meet somebody's own interest to say that I need to make sure I'm keeping people healthy as opposed to providing for them when they're unhealthy? And it's going to require a lot of difficult policy choices. So there's individual choices we make, but it's going to require very difficult policy choices of how we decide to allocate healthcare dollars. Not the best answer, but the best I got for you at this point.
Any other questions?
So something you just said caught my attention. You seem to take the position that many conservatives do, that it's actually one of the causes of the very high cost of healthcare today is that by creating things like Medicare and Medicaid, we've artificially driven up prices. We've created a vast pool of money that business can target that they wouldn't have been able to previously. If they had to compete for just our individual small change, they'd have to offer health care at lower prices. I'm not saying I advocate that, but do you advocate that?
No, not at all. So thank you for that clarification. I don't think this is a conservative or a progressive issue. I think it's a philosophy issue. So it's not the dollars in the system as opposed to the way the dollars are used. And if you've decided that the way you're going to use all these dollars is fee for service, you are going to do service, right? If you decide that all these dollars are going to be value-based and that your reimbursement will be based on how healthy I am as your patient or how healthy Jenny is within your community, you still have the same dollars, but you have those dollars for a different purpose, right? So I don't think it's the dollars as much as how we've decided to allocate those dollars that are a problem.
Okay, we have time for one more. Zach?
So I was very interested in the sort of healthcare 3.0 point that you were making about sort of unifying healthcare and public health. I think it's a great idea in principle. I was curious to what you thought about running up against sort of patients' fundamental expectations of privacy, doctor-patient confidentiality, if we're using patient data to sort of get an amalgam statistic of the community standard. Does that amount to human experimentation? And if so, do we need to expand IRB to sort of encompass, the sole general practitioner's office? I was curious to your thoughts as that.
That is absolutely a brilliant question for this audience, and I think why I put that up as one of those critical health law issues that you are going to help solve, not me. But we already know that this is already happening. So I gave you examples, for example, systems in California where the county is the payer, and they notice somebody bouncing in and out of the county hospital multiple times. And it makes more sense for them, and I'm not sure this is an experimental issue, but it makes more sense to them to ask the patient, do you have housing, and provide them housing. So I see it as a social responsibility issue as a clinician or a healthcare system to have a holistic view to your patient. With the doctor-patient relationship, you know a lot about the patient, but sometimes just having a sort of a community propensity score may give you more information of what to do with that patient. And think about it, the old examples, which we don't use very much, is around drug prices, right? A patient would walk in, you'd write them a prescription, and you'd not think about what is the cost of that prescription to the patient. And, he or she may be too embarrassed to say, Doc, could you write me a generic, or could you write me something cheaper? And they walk out with a drug that's not used. And I think the data suggests 30% of, somebody probably has it better than me, 30% of prescriptions are never filled or something like that. There's a significant proportion of prescriptions that are never even filled. Not the ones for the OxyContin, those are filled. But if it's not for the OxyContin, they're not filled. But you're right, these are these critical issues of how do we make sure we're maintaining the patient's privacy while we're trying to connect them to services and resources within the community. Thanks for that great question.
Well, thank you. This was fabulous. And I would like to give Dr. Kahn our plaque for being our Schroeder Scholar for 2017.
And
And please join us for a reception outside.